Thank you for joining us for the October edition of Coffee with Coker. As always, it's a privilege to have you join us. Immediately following today's presentation, we will have a question and answer period, so please feel free to submit your questions throughout the presentation in the area provided in the GoToMeeting dashboard. The participant phone line will be muted for today's presentation, and the materials will be emailed to you tomorrow. As you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Annette Sullivan, Senior Manager at Coker Group, will be leading our presentation today, and Dr. Ellis McKnight, Senior Vice President and Chief Medical Officer, will be joining to provide his input as well. Please join me in welcoming Annette and Dr. Knight.
Good afternoon. Thanks for joining us today. We're very grateful that you chose to spend this time with us. This is the third week after the lifting of the ICD-10 freeze. I know you all are busy with becoming familiar with the more than 7,400 changes for fiscal year 2017. As you all probably well know, there were 2,305 new diagnosis codes and 3,836 new procedural codes. So in addition to the lifting of the freeze, there was also a lifting of the moratorium on the leniency for denials and audits for Part B for inaccurate or specified codes for, as long as there would be no denials or audits as long as the code assignment was in the correct family of codes. So that's been lifted as well, and I really feel like they were being lenient on the inpatient side as well. So with that being said, this is a timely discussion to talk about specificity and accuracy in coding, and just to look at the new revisions and code updates. So today we're going to spend a little bit of time at a very high level talking about some of the 2017 ICD-10 coding rules and guidelines, and we'll look at some of the new and revised diagnosis codes and procedure codes. We'll also look at some of the ICD-10 focal points as they relate to documentation, and then we'll talk about some performance improvement education and leave some time at the end hopefully for some questions and answers. One of the first things that came out of the new revisions, as you all know, the excludes one note was if you had an excludes one note prefacing a code, then you couldn't code those two codes together. And now there is an exception to that, that the codes may be assigned together if the two conditions aren't related. And an example of that, if the patient had chronic blood loss anemia due to problematic menses, and they also had a duodenal ulcer with acute blood loss, those two codes can now be coded together. But the caveat to that, coded together, the caveat to that is that it has to be clearly documented, that exception. So that was something right away that affected our documentation guidelines and principles. You have to make sure if you're coding those two codes together that it's clearly documented why that is an exception. And then the next thing is the etiology and manifestation. This applies to sequencing. So the underlying condition must be sequenced first, followed by the manifestation. And I use an example here of Alzheimer's disease with a behavioral disturbance. Alzheimer's would always have to be sequenced first before the behavioral disturbance. And then, of course, we have the Coma scale. This is very important and new this year. It's one of those things that allows for coders and clinical documentations to use the clinical documentation specialists to use the documentation provided by someone other than the provider. And this is one of those examples. So the the documentation for the Coma scale is listed here. I have a Coma, and then you have the Glasgow Coma scale there. And some of those, you want to make sure that you get that documented, and you may want to start out adding procedures of how this is going to be accomplished, because a lot of those, depending on if you get the specified documentation, it can get you an MCC. And likewise with the documentation for the stroke scales, this is very important for a lot of the initiatives, especially if you're in a stroke center. Joint Commission required this to be documented. I believe it was January 2016, but this is another option for providing documentation for the stroke scores. And the scores go all the way from 0 to 42. One of the other changes was the Zika virus, and you have to remember that you can only code and document and confirm cases. So if the provider only documents possible, suspected, you cannot assign a Zika virus code for that. You must code the reason for the encounter, which it could be rash, fever, pain in the joints. So if you're coding Zika virus, it has to be clearly documented that it's confirmed. You don't have to have a test that confirms that. Just the physician documenting that the patient has the Zika virus is enough. And the next things were the hypertensive crises, and that was urgency and hypertensive emergency. And I'm going to pause here and let Dr. Knight give you some clinical information about hypertensive urgency and emergency.
Thank you, Annette. And let me just say that I think this is a great example to use in terms of the translation process that needs to occur between coders and coding parlance and what ICD-10 now calls for and how it classifies clinical conditions and the use of clinical terminology with regards to actual practitioners. When Annette asked me about this, I took the liberty of looking up in a reference manual that I use quite frequently in clinical practice, Up to Date. And it's interesting because ICD-10 describes hypertensive crisis, it describes hypertensive urgency, and it describes hypertensive emergency. If you look at Up to Date, which again many of us use to define things clinically, it talks about severe asymptomatic hypertension, which would be what they would call hypertensive urgency, where the blood pressure is significantly elevated, usually diastolic blood pressure above 120, but however there are no clinical signs or symptoms related to that blood pressure elevation. What they then call a hypertensive emergency is where you have that degree of elevated blood pressure with clinical signs or symptoms of stroke or acute coronary syndrome or other clinical manifestations of the elevated blood pressure. What I can't really find is where clinical parlance and ICD-10 would come together with regards to hypertensive crisis. I would presume, and again this is just my interpretation, that hypertensive crisis would take into account either urgency or emergency, and so that's kind of a grab bag term for both of those. And then the urgency would be without symptoms or clinical signs, and the emergency would be with symptoms or clinical signs. And so hopefully that helps those of you that have to, again, make that translation for your clinicians and helps you interpret these new guidelines.
So appropriate coding for the hypertensive crises now is going to be very dependent on differentiating between urgency and emergency. So you're going to have to provide a lot of education to your coders, to your providers, and your clinical documentation specialists to ensure that you are appropriately capturing those diagnoses. One of the other important changes this year was the term with, and as you can see on the slides, I use the hypertension with heart disease or hypertensive heart and chronic kidney disease. The with, the 2017 guidelines assumes a causal relationship between the hypertension in this example and heart disease. Now, as we all know, it's very hard even before to get a physician to document the causal relationship. And likewise, it's going to be, and the rule says, or the guideline says, that you can assume a causal relationship without the provider providing the documentation unless they document an exception. So it's going to be equally as hard to get a physician to document an exception. So you're going to have to kind of do the opposite and make sure that the coders and the clinicians are able to identify the symptomology for those exceptions and then have the physicians document that if it's not present, because we want to make sure that we are accurately painting the clinical picture of really what's going on with that patient. So just like it was very important to get them to document the correlation, it's going to be equally as important to document those exceptions. Another change is the acute MIs now. We know that the rule has been changed that if the patient is still showing symptoms or having issues with the acute MIs, you can still report those for if it's equal to or less than 4 weeks. And this is going to be very important, especially for those facilities that are accepting those patients in transfer. It was always very frustrating for those facilities when they accepted those patients, but they couldn't report that MI. So this is something that you want to make sure that you're taking advantage of and adding those as reportable diagnoses. Pressure ulcers were also revised. It addresses a pressure ulcer that was documented on admission, but by the time the patient was discharged, it's documented that the pressure ulcer has healed. So the guidelines state that if that occurs, you must code that as a documented pressure ulcer, document the stage and the state of the pressure ulcer at the time of admission. There's also a new rule that talks about evolving stages. And for example, if a patient comes in and they have a pressure ulcer of the sacral area that is a stage 2 and it evolves to a stage 3, you code that to the highest level of, and you wouldn't code the stage 2, you code the stage 4. And I believe this is going to be very important to make sure that you're documenting this, because this is going to affect those performance indicators that are tracked by hospital. I don't know if Dr. Knight wanted to add anything about that, but that becomes, to me, this is kind of a sneaky way for them to start tracking performance of how you're taking care of those patients and those ulcers when they come into the facility.
Yeah, I think this is, I agree with Annette totally. As many of you know, clinical documentation and coding now is not only important for billing purposes, but it's important for quality reporting purposes. And one of the big things that are going to be reported more and more are hospital-associated complications, hacks, and one of those is, a good example of that, again, is pressure ulcers. So again, knowing exactly how to document that and how to code for those is going to be extremely important, not only so you get paid appropriately, but also so that your quality performance is tracked appropriately, and either you get credit for, again, documenting something like a pressure ulcer that's present on admission, and what its status was by the time of discharge, or documenting the progression of a pressure ulcer that occurred during hospitalization that again may affect quality performance scoring and subsequently reimbursement. So good point there, Annette.
So to that end, it's going to be very important that you are appropriately capturing that information, whether at the time of admission, especially if they come through the ER. You want to make sure that you're getting the information there to appropriately reflect that ulcer, what stage it was when they came in, if it was present on admission, and what the stage was. Because now, if they put this in here, they're really going to be looking to make sure that you're documenting this appropriately. And they're looking to make sure that you're providing the care to keep that from going from a lower stage to a higher stage. So you want to make sure that it is documented quickly as soon as the patient gets there, and that you are appropriately assigning those codes. There's also a new code this year for the oral hypoglycemics. There was always a code for the insulin, but they've added that, so you want to make sure that you're capturing that information. As far as coding rules and guidelines for the procedures, you want to go over those in detail with your coders and also the physicians so that they know the changes that have occurred. And the root operation revisions I've listed here are control, creation, and repair. There's a lot of things related to cardiology, cabbage. So you want to make sure that the coders and the clinical documentation specialists as well receive those new guidelines and know the new root operations so that they can assign the appropriate codes. There's new root operations for perfusions and several for new devices in the technology codes. Moving on to the focal points, Dr. Knight talked about the hypertensive crises, but we also want to talk a little bit about the acute ischemia and acute infarctions of the intestine, because there are new codes for those, and you want to make sure that you're coding those appropriately.
So let me jump in here and just say that many of you are probably familiar with using these intestinal ischemia and infarction codes with regards to ischemic enterocolitis in newborns. What the ICD-10 changes for 2017 do is expand this beyond newborns and into the realm where I'm more familiar with as an adult provider, into adult patients or children beyond the newborn stage. And here again, this can be associated with vascular disorders, atherosclerosis. It can be associated with infections. It can be associated with inflammatory disorders of the bowel. And there's various stages, stage 1 being necrotizing enterocolitis, stage 2 and stage 3 necrotizing enterocolitis that again are defined by the degree of ischemia and changes in the bowel wall and the extent of that. So it's important for all of us to remember this as it relates to not just newborns, but to children outside of that age range or in adults.
And one thing that you want to remember with these ischemia and acute infections of the intestine, if you have those codes, they affect the HCC risk-adjusted system, which is equally as important on the inpatient side as it is on the outpatient side, especially with value-based purchasing. But even if you don't have Medicare Advantage, they also affect payers, because there are a number of payers that use the risk-adjusted system to determine how they're going to reimburse and how they're going to award contracts. So you want to start paying attention to those diagnoses that affect the HCC risk-adjusted system, and this is one of those that affects that. There's also a cerebral infarction code revision, and that really speaks to specificity, because now they really want you to be able to discern which arteries were affected and which side, and there's a new code for bilateral. But this is where you really need to educate the physician about documenting clearly where that embolus or damage has occurred in the cerebral area. Did you want to add anything to that, Dr. Knight?
Just that, again, as a clinician who has managed a lot of stroke patients, I think this is going to require a lot of education for your providers in order for them to take the time to document the location and the anatomy of the embolus or the thrombus as you're looking at this. It's not simply going to be a matter of, you know, stroke with left hemiparesis, but again, you're going to have to define that more clearly. And with new therapeutic modalities for stroke intervention, I think that's appropriate because, again, some of those therapies may come into play or may be indicated or not indicated depending on the location in the vasculature that is involved here. So again, education and training of the physicians and other providers that treat stroke patients is going to be very important.
Acute pancreatitis was another one, that category that was revised, and it was revised to describe idiopathic acute pancreatitis, biliary acute pancreatitis, and also alcohol-induced acute pancreatitis and drug-induced. So there's also a fifth digit that has to be classified as without necrosis or infection, with uninfected necrosis, or with infected necrosis. Do you want to add anything to that?
So I think with regards to pancreatitis, the important point here is, and again, I'll criticize my own profession a little bit here. We've been, up until this time, rather sloppy sometimes in our specificity in diagnosis and discussion in the medical record with regards to the etiology and extent and severity of common conditions like pancreatitis. The importance of this, again, is that taking the time to define that more can really bring out cases where certain therapies are indicated, certain aren't, and also can define the severity of illness, which would then indicate treatment in a higher level of care than, for instance, a simple case of pancreatitis that may even be treated on an observational basis as opposed to a fulminant pancreatitis with necrosis that would require full-blown intensive care and very aggressive therapy. So without that kind of documentation and without that kind of coding, it's going to be very difficult for payers to pick up on the appropriateness of therapy that was rendered, the level of care that was provided, and make determinations as to whether that was appropriate. So again, as much as I might not like to have to be bothered with all this specificity, and I'm sure many of the physicians that you're going to be talking with will not either, it is going to be important as we go through the future use of these codes to make sure that they're used appropriately so that we can get appropriately paid and reimbursed for the treatment that we do render.
Sepsis is also on here, but it's not new this year, but I have some friends that work for the dark side as auditors, as I like to tease them, and they say that they're still seeing a lot of denials issued for sepsis sepsis being assigned inappropriately. And everyone should familiarize themselves with the new guidelines that came out last year. It's no longer enough to have someone diagnosed with severe sepsis just based on those clinical conditions. It has to be organ failure, and I'll let Dr. Knight expound on that more.
Yeah, again, I think sepsis is probably one of the most common clinical conditions that there's a significant amount of ambiguity about. The coding criteria have been worked out fairly specifically, and I would dare say that Annette and I work together a lot with different organizations to help them with the clinical documentation and their coding audits, and this is probably the one that requires us to get involved the most and requires the most education and understanding. So I won't belabor all the details of sepsis coding here, but this is a hugely important topic, and I would definitely encourage all of you to be very, very up to speed on the criteria and the information that you need to code sepsis accurately, and make sure that your frontline providers are likewise educated and knowledgeable about that.
Okay. I'm going to address the Coma scale again. The 7th digit allows you to identify where the scale was assigned. You want to differentiate between whether it was in the field by the EMT, or was it upon arrival to the ED, or 24 hours or more after hospital admission. So you're going to have to, if you're going to assign these scores, you're going to have to make sure that that's documented so that you clearly enough so that you can assign those codes appropriately. And you also need to understand that you can use these Coma scale codes to assess CNS for other non-traumatic conditions. In other words, for other patients that are on the ICU or on those trauma units. So with all of the new changes, I mean, there are a number of things that you can do. I mean, there were over, like I said, 7,400 either new codes or revisions. So the best thing to do to make sure that you are coding appropriately and maintaining your quality requirements and also not impacting your revenue in a bad way, you want to make sure that you become familiar with all of the new codes and or the new guidelines. And then once you do that, it's probably a good idea, if you haven't already, to go ahead and assess your documentation to identify where those gaps are. And one way to do that quickly is to look at and see how much you, as coders, are assigning unspecified codes, and then go in and review some of those records to determine if it was truly unspecified, and then look at why the coder had to resort to assigning an unspecified code. And then once that's determined, you're usually going to see some trends and patterns. Go after those areas or the physicians that are costing you and educate them so that they are documenting to the level of specificity that allows you to assign a more specific code. And again, you want to make sure that you are accurately capturing what's really going on with that patient. So unspecified codes should be kept to a minimum, and the use of those codes should be decreasing. With all of the new procedure codes, it's a good idea to go through some of your operative reports to make sure that you are getting quality documentation that allows you to appropriately assign those procedural codes. So I would spend some time with a lot of the cabbages, the coronary procedures, revisions that came out, look at those and then review your operative notes to ensure that you have the reports that allow you to code those appropriately, and then if not, educate those surgeons so that you can code appropriately. You also need to look at the quality of coding and make sure that the coders don't need any additional education. Do the same things with your other documentation as well to ensure that you're getting enough information to assign those codes appropriately. And then do consistent education and educate the physicians and all of the new things like the Coma scales, the guideline that allows coders to assign codes by assuming a causal relationship. You really need to educate the physicians about that and then get their feedback. And then Dr. Knight's raising his hand. He has something he wants to add to that.
What I would encourage everybody to do, and again, I think every time ICD-10 education comes up, all of us feel kind of overwhelmed. There's 7,400 changes in 2017. There was who knows how many thousand that came out when it was first rolled out in 2015. So it's a daunting prospect when you start thinking about going and educating your medical staff or your provider staff with regards to ICD-10 codes and appropriate documentation related to those. What I would encourage you to do is to break it down into small pieces and focus your education on specialty by specialty that you can then get it into a smaller number of key codes and key bits of information that need to be transmitted. I'm a hospitalist by training, and you know, I think that it would be relatively easy for me to design a top 10 list, if you will, of ICD-10 codes that I think every general hospitalist ought to know about and be aware of. We've already talked about some of those today, such as the coding of pancreatitis, such as the coding for enteral colitis. Those are the kind of things that, again, you see a lot as a internist, hospitalist, and you could design a list like that. Likewise for cardiology with regard to the AMI codes that we were talking about a little while ago. Likewise for orthopedics, where you're talking about all these different codes for fractures and how to define those. So again, break it into small pieces, focus your education by specialty, putting physicians of all different types of specialties in the auditorium and saying, today we're going to teach you all about ICD-10 is probably an exercise in futility, but getting your hospitalists together and say, we're going to talk about the top 10 things that you see in your practice, likewise with orthopedists, likewise with cardiologists, will probably pay dividends. If you don't have the capability to do that, bring in somebody from the outside to help you with that kind of education. That's, I think, the way to do provider education and make it most valuable.
And I think you're right on that. I mean, that's why you're going to review the documentation to determine the documentation gaps and deficiencies, and then you focus and target those physicians and those specialties that are causing you the problems. It's also going to save you some time and energy. You can also run reports and focus on the areas that the OIG focuses on and use that for quality review and education. You also need to spend some time and look at the 2017 list of CCs and MCCs and make sure that you understand how they impact the DRG. So use that for education as well. The key is education for your providers, focus education for your providers, consistent education with your coders and your clinical documentation specialists. You also want to make sure that those two sets of groups spend time providing education to each other and supporting each other. They can build on each other's strengths, and also developing a good relationship. A lot of times those two areas are not in the same area. And so one thing that's very important for success is to make sure that no matter where the reporting responsibility lies, that you are working together as a team. The last bullet point that I have here says to establish an integrated service model for PI and for clinical documentation improvement. I mean, you want to make sure that you are maintaining an optimal revenue cycle, and that in order to do that, you have to have revenue integrity and data integrity. In order to do that, you're going to have to kind of think outside of the box and change the way that you're doing things. Gone are the days where coding quality and documentation just resides with HIM, or it just resides with the clinical documentation area. All of those areas have to work together as a team, and they have to work with performance and with quality. And you also need to expand out to the physician practice area. You can, now's the time to start an integrated model where you have an outpatient CDI area, and you're working with the hospital to get the documentation right the first time, the right level of service. And that way you're not spending as much time trying to improve things retroactively. You're doing that while the patient's in the bed.
Yeah, let me add to that and say something that probably each of you know. I'm sure you do, but let me just emphasize it. And that is that the reimbursements system for healthcare is rapidly, I mean rapidly, moving towards a value-based reimbursement model, meaning that payments, especially from CMS, but commercial payers are following suit. Payments are going to be dependent on performance with regard to quality outcomes and performance with regard to cost efficiencies. And how are those quality outcomes and cost efficiencies measured? They're measured through these billing codes. And so when you document and code the things like pressure ulcers, things like falls, things like hospital-acquired infections, things like readmissions, etc., these are very, very important in terms of being used not only to document the clinical reality, but also to determine the performance of the providers in your organization and their performance-based or value-based reimbursement. So there's a new payment model for physicians that's getting ready to roll out in January of 2017 called the merit-based incentive payment system. That's going to include all these things that I mentioned. There's already in place, as many of you know, a value-based payment model for hospitals that take into account things like hospital-acquired conditions, things like readmissions. And so coding is no longer simply a process that makes sure that the appropriate DRG is assigned or the appropriate clinical condition is defined, but it's extremely important in terms of documenting quality performance, and then that quality performance determines more and more as we go forward reimbursement for both providers and for the hospital.
And that being said, it's very important to make sure that your compliance plans and your compliance manuals are up to date. You should have included last year, updated all of the things that pertains to ICD-10, and it's always a good idea to update those each time the new codes and guidelines are distributed. So that being said, we're going to move to questions and answers.
I think Savannah mentioned this at the first of the webinar, but if any of you have any questions, please send them in. Please communicate them through the website, the GoToWebinar site, and we'll be glad to ask that or answer them, or try to the best of our abilities. Let me start and ask Annette a question, and this is something that I was thinking about earlier. Annette, you've got a set of providers, and you mentioned the Glasgow Coma scale, and you've got EMT providers in the field giving Coma scale information. You've got your emergency department personnel assigning a Coma scale score. You may have your trauma team that's admitting the patient and managing that patient over time. If those don't match up, if, for instance, the EMT says the Coma score is X and the time the patient gets to the emergency department, the emergency room physician says it's Y, which one of those do you use for coding purposes?
If there is a discrepancy, coding guidelines mandates or suggest that we issue a query or a clarification to the physician to provide that clarification so it's clear.
Okay.
There's also another question that says for pressure ulcers, if the patient has one stage on admission and it evolves to an additional stage at a higher stage, what POA indicator do you use? In other words, if they go from a 2 to a 4, do you mark that 4 as present on an admission? And the answer to that is yes, because it was present on admission.
But let me jump in and clarify that. The present on admission documentation would be documented as present as a stage 2, correct? And then the discharge status or stage of that would be documented at a 4. Would that be correct, or would there only be one documentation for the pressure ulcer, and that would be a 4, or the highest one that it was during the hospitalization?
I think I answered that wrong. It should be no. That would be no, because it wasn't present on admission.
Yeah. So the stage 4 was not present on admission.
It was not present on admission.
Yeah, it was stage 2 on admission, and then evolved to stage 4.
Stage 4. 4 is not present on admission. Okay. Apologize for that.
Yeah, and I think that's relevant also to the discussion we had earlier about, again, quality performance. So if you documented that a stage 2 pressure ulcer was present on admission and it was still stage 2 or better by discharge, you should not be held accountable for that having a negative consequence to your quality performance. But if it was stage 2 on admission and on discharge was stage 4, that would have a negative ramifications for your quality scoring and could adversely affect your performance scoring. Anybody else have any other questions out there?
So there's another question that says there are many conditions in the coding classification with the words with and the subterm. Are we to assume a causal relationship for any condition listed that way in the index, regardless of whether the physician documented it that way? And that would be yes.
So let me ask then, so with really implies a causal relationship.
Correct.
Okay. And that kind of goes back to our one of our initial discussion topics, which was the association of hypertension with heart disease. I think you and I talked about this a little while ago, Annette. It would be logical in many cases to relate hypertension to heart disease. However, there are a lot of types of heart disease. Heart disease is, of course, a big, giant category of diagnoses. And there's a lot of types of heart disease, infiltrative disorders, valvular heart disease, infections of the heart, neoplasms of the heart, etc., that may have nothing to do with hypertension. So I think that's one of the reasons why they came out with the qualifier of hypertension with heart disease or hypertension that's not related to the heart disease that's also being classified and coded for.
Okay. We have another question. We have never assigned codes for the stroke scale and coma scale. Are we required to do so now? You are not required to do it, but again, you might want to check with your performance or your quality department before deciding not to, because a lot of that information for stroke is important for some of the information that they are capturing, and also if you're a stroke center, it's probably a good idea. I believe Joint Commission required that information that we start collecting that. That should have been January 2016.
Yeah, I would agree with that, and I would say if you're a trauma center, if you're a stroke center, you may not be required to capture that, but it certainly may be important information that will go a long ways to getting accreditation and having quality ranking of your stroke or trauma center. So important to make sure that your coding is supporting the performance ranking and measurement of those clinical service areas that go on in your organization.
And it's probably a good idea with the coma scale and the stroke scale to get neurology, the Department of Neurology's input on whether they want that information collected. It should not just be made by one department.
Yeah, and I think it's important also when you're talking about those sort of things to make sure that everybody's literally working off the same scale or using the same definitions. You don't want your emergency medical services to be using one scale, your emergency department to be using another, your trauma team to be using a third. You want to make sure that you're using a scale that allows you to compare apples to apples, oranges to oranges, etc.
Okay. Any more questions? Well, I've listed my contact information. If you have some questions and you want to send later, feel free to call me or email me with that question. We'd be glad to assist you with any of your efforts as it relates to clinical documentation improvement or coding, auditing, or support, anything HIM related. Please feel free to contact us at Coker Group. And thank you time to spend with us today.
Thank you, Annette and Dr. Knight, for that presentation. Like Annette said, if you have additional questions, you can feel free to reach out to her directly, and she will get those answered for you. Again, we would appreciate your feedback on this presentation through the survey as you exit the webinar. And the slides for this presentation will be emailed to you tomorrow. And we thank you for joining us today. Have a good day.